And today we're specifically looking at the Biopsychosocial Approach, which is the second standard in the All Wales Best Practice Standards for Community Services. And again, so just to remind people why we've chosen these standards as a basis is because we feel that they're broad enough that they support any service to implement these really core, crucial standards without discriminating services that are a bit more specialist than others. So it'll help us to encapsulate all services that provide neurological community services to patients. So this is our agenda today. So we've done a bit of a welcoming introduction. We'll get into the terms of reference shortly. We'll look at some of the previous audit and evaluation from the last session, just to highlight a few little areas and to reassure a few people on some of the comments that were made. Then we've got Linda and Bronwyn from AB UHB discussing how they use and approach biopsychosocial approach. A bit of discussion then, and then based on some of the feedback we had from the last session, we're looking at breakout rooms to try and do a bit more interactive sessions, but specifically looking about what is required in services to deliver on this standard of care. And then also looking at barriers and levers. So a little bit of housekeeping. We are recording the session. It will be available for freedom of information if required. The full session and the main meeting will be available on a YouTube link, which we'll post on our website following the session, which is to support people who don't have access to the recording following the session because they don't have access to Teams. And then the breakout rooms that we'll be going into, there'll probably be 4 or 5 breakout rooms. We'll be recording each of those, but that'll be for transcription purposes only. And then just a little bit of etiquette, if possible and you're willing, please keep your cameras on and microphones off. And I know what it's like when you're on these meetings, your eyes are darting around the screen because you're on different emails and screens. But if you can avoid that temptation, just to give people the full respect and to sort of listen to what they've been developing to try and fully engage in the session, that would be welcomed. So terms of reference, I know that this can take a little bit of a while for to sink in. I don't think we've had any comments on the terms of reference that we circulated last time. I am going to go to the terms of reference just to highlight a few key areas. I'm not going to go through line by line because I think that would be a tough task for anyone in this session. I think our numbers would drop off pretty quickly. But just broadly talking, and we're going to circulate these again and ask for comment and for any sort of questions or queries about them. But I've just highlighted a few areas here on the roles and responsibilities and remit of the group, and just that we'll primarily be acting as a subgroup to the National Strategic Clinical Network for Neurological Conditions, and it's to support a coordinated approach to the development of neuro rehab services, and obviously specifically the community aspect of those services, but appreciating that they'll be branching out into other services that feed into neurorehabilitation pathways. So the purpose and aim is that it'll provide a strategic lead for the national neuro rehab priorities and is aimed at services supporting people with neurological conditions in the community. And that its primary aim is to improve the sharing of best practice and sharing the benefits of different ways of working, different service models, and supporting the spread and scale of those models and that innovative practice. And we'll have a responsibility to support the implementation of best practice rehabilitation standards to ensure patients have equitable access to high quality neuro rehab. In terms of accountability, so this group will be accountable to the Strategic Clinical Network for Neurological Conditions, which is NHS Executive, but is now Performance Improvement. So it's a name change, but the function is the exact same. So we will update this to represent that, but the function of the networks is the same. And then from a chair's perspective, that is currently myself, and I'll have the responsibility of escalating any issues to the network. But also members will have a responsibility to disseminate information both from and to their respective organisations or other groups that they're involved with, and that they have the knowledge and delegated responsibility to make decisions on behalf of their organisation within the boundaries of their responsibility. So that links in with the disseminating of information and sharing that information. So to use your expert knowledge to help advise on current systems and structures and best practice working. And then to share the best practice from this group with others within their organisation. And then, as many of you have done already, to engage in that reflective self-evaluation process to improve the group effectiveness as well. And then in terms of membership, I've highlighted a few points here about it. It's open to any individual working in community services supporting people with neurological conditions or have an interest in that. And additional to that, it's additional representatives can be added as an ad hoc basis depending on the topic or the agenda. So previously we had the co-production Wales come and join us for one session, and we've got some guest speakers later in the year as well. I can see your hand's gone up. Stuart, would you like to come in? Oh, you're on mute there, Stuart.
Sorry, I thought I'd turned mute off. Just a quick point, it might be not relevant at all, but often in this type of an environment, you have a professional chair and also a lay chair, so that there is lay representation at the top of the meeting. It may well not be appropriate in this environment. I appreciate I'm very much late to the show on this, but I was just interested to hear what others' thoughts might be. Thank you.
Thank you, Stuart. If I could come straight back on that, there's a point further down which is about the chair, which is the last point here, about a nominated deputy chair. And we've spoken about this in the network, and I'm in agreement with you that there needs to be someone who's not necessarily professional, and they're here for maybe their lived experience or third sector. And so I'm very happy for that to be nominated. In terms of how we determine a lay chair or deputy chair, that is the one thing I'm hoping we can have some comment on, or some suggestions from the group as to how we go forward with that. So if anyone's got suggestions now, I'm happy to take them, or if we'd like to have an opportunity to read the terms of reference and come back to us and make some suggestions, I'm happy to do that then as well. I can't see everyone, so if anyone's got a hand up, could someone just let me know, please? Okay, so I think, well, that's sort of the oh, there we are. Hi, Linda.
Only if it's helpful. Just I think certainly in Iron Bevan we've got a growing network of peers and partners, that and there may the same framework might be present in other health boards. To keep it fair, it might be that we can bring it to our peers network and ask if anyone's interested, and maybe have a bit of either a, I don't know if you'd have an interview process or a ballot, but yeah, I think there'd definitely be people interested from our health board, I'm sure.
Okay, that's lovely. Thank you. I think what we'll probably do and take as an action is to recirculate this with a time frame to it, and ask for comment on all of it, but specifically how we go about ensuring that there's appropriate representation of the right people, and that there's a, as you say, Stuart, a lay chair alongside, or a deputy chair, however we term that. So there's no other comment on terms of reference. I think I'll just take it forward that we'll recirculate, and we'll look to get some comment from yourselves about that. So I'll just flick back to the presentation if it works. So moving on to the next item of co-production analysis, and I just wanted to go through some of the results we had from the self-audit and the evaluation that we sent out after the last session, just so people can see why we're collecting it, and give us some insights if they feel we need to make some changes. So we did ask for some comment on the evaluation form that we did put together. We didn't have any comment. The self-audit form is standardized as part of the best practice standards, so we can't change that per se, but we might be able to influence how we relay some of that information. So this was the self-audit for service providers on the co-production standard. So these are the questions that people would have been faced with, and it asks for agreement to the standard. And I've highlighted in yellow the most sort of chosen answer. Sorry, yellow, green. My eyes aren't playing this morning. Which is the most chosen answer, and you can see that people are largely agree that they're providing on the standard. When you go to service users, it's a little bit different. So I know the numbers are a lot lower because that was representative of the numbers in the groups. There's only 4 in the group. So I appreciate that is a limitation, but there is a subtle difference in that. And what I've tried to do is draw out some of the specific questions that are similar in wording, but essentially mean the same thing, just to try and draw on that subtle little. And I know the numbers are small, so bear with me. So this was about what matters to me. So on the left, we've got service providers. On the right, we've got service users. On the left was identify what matters to you rather than what's the matter with you. There's the same question then to service users. And there's huge agreement amongst providers that they do provide on that standard. Service users, a bit more middle of the road. still mostly agreeing. If we had large numbers, I wonder how that would look. The next question I've highlighted is about the holistic care, and that it's co-produced and holistic. So we've got service providers on the left again, service users on the right. And again, large agreement and service providers that they're delivering on this particular aspect of the standard. Middle of the road again for service users, again acknowledging that the numbers are lower. When does my rehab stop was the other question in the self-audit. So on the left, we've got service providers, on the right, service users. Similar sort of thing. There's a bit more discrepancy in the service providers on the left, and middle of the road service users. I suppose what my point is about this is that there is some subtle differences between providers and users, and it might be useful in services to try and capture that on a broader scale amongst the populations that we're serving, to try and understand if there are differences between how we feel we're providing on a certain standard and how others are, how they perceive the standards being delivered to them. So it's more of a suggestion than anything else, but just to say we've noticed a little bit of a difference. I wonder what will come out today, but again, I know that the numbers aren't strong, but they are representative of the group that we had in the last session. Then we were trying to capture some evaluation information about how useful people found the last session. And we had some comment sections as well. So largely 53% people found it very useful, 40 found it extremely useful, and 6 were neutral. There was no sort of unconfident or very unconfident responses in relation to how useful the session was. There was then a comments section where people were able to put the comments that they felt to expand on those scores. So the first 2 comments I want to draw attention to were the top 2 here. So it says needs more input from Welsh Government and more decision maker input. I just wanted to reassure people that we are the decision makers in this forum. As what was the exec and is now performance improvement, we've got a very clear mandate and remit letter from Welsh Government. Our role and responsibility is very clear. We know what the quality standards are, and we have the ability to influence and support change and implementation at local level in collaboration with health boards. We don't necessarily need Welsh Government in this meeting. If they wanted to attend, they could, but we have regular meetings with our Welsh Government partners, our policy leads. They're aware of the work plans. They're aware of the work that we're doing. If we felt there was a consensus amongst this group that there needed to be a national change in this area, community neuro services in the community, it's within our gift to write that up as a consensus based in evidence and data. And we could then publish that as a national consensus document. It'd have to go through the ratification of the Performance and Improvement Unit. So that would be through the SLT, the Senior Leadership Team and the Directors Group in support of Welsh policy leads. But we could then issue that as national guidance and consensus, which in theory could be used to audit health boards against, to support change and improvement, not to tell people off, but to support change and improvement. So for example, what is a really big thing across the networks at the moment is development of service specifications. So they would be developed in forums like this through consensus and data and evidence about what service requirement or services require in place to provide a standard of care. How that's delivered is up to the health board. So that might mean they have different services providing that level of care, but that level of care is available to the demographic they serve. We would then be able to request information or audit the health boards against that standard or service specification, and then support the implementation and change and making suggestions on how things can change. So it's within our gift to do that. That might not be as a whole group in our entirety. It might be that we take elements of work outside of this group into smaller groups to develop and then bring it back into this group for conversation and comment. But that is within our gift. So we don't necessarily need more Welsh Government in this meeting. They can come along if they want, but we are the decision makers. Then there was a comment about just keep it involving us in the work and we can save time and money. And I'm assuming this was someone with lived experience, a person with lived experience who gave this comment, and completely agree. And then that linked in really nicely with the last comment, which was about future sessions would be a bit more useful to have interaction discussion. So we've taken those 2 points and we've changed the way we've delivered the session today to make sure that we've got people with lived experience and have a very strong voice in the area that we're talking about. And then we've brought that into an interactive discussion. So I really hope that those voices come forward today and help us understand what needs to be in services to provide on this level of care. Then there was another section where we asked people, what could you do and what will you do following the co-production session? And these are some of the comments that came back. So people were essentially sort of saying what they were going to do. Setting up mailing groups, reflect as a group, going to create a mailing list and audit our understanding of co-production. And so this is a question to the group. How best do we as a network share this information back to the group to support implementation? So there might be suggestions of collating them and reporting them at certain periods of time through the year. Do you want them after the sessions? Do you want us to use it as audit information to say, have you done this? Do you want us to take it as an action? How do the group feel we need to take this forward? So that is a question, if people would be prepared to comment now.
Hi, Nick. Can I just mention one thing?
Sure, John.
Looking at we've gone through all the the tick boxes, but is there, so patients like me with dystonia have a treatment in Cardiff, but have a rehabilitation and psychology service in Cwmtaf. So when it comes up, where are you having your treatment? In Cardiff. Cardiff treatment may be good, but it may be poor in Cwmtaf. So it's like that, although we have treatment in all our treatment in Cardiff, we don't, maybe we don't have the rehabilitation in Cwmtaf. Just like say that. So.
Yeah. Okay. So is that something for us to consider when we provide the evaluation forms and self-audit, to try and give you an option to comment separately on the services you have?
Yeah, from a patient point of view, what we picked up in neuro cafes, that patients didn't know what's available to them, like psychology services. How can you put a lot of people through psychology when stroke services are very high in rehabilitation? So I'm not sure. We got 600 neurological conditions in Wales, but only able, so I think stroke services in Cwmtaf last time we spoke was that they're having 3 patients a week referred in Cwmtaf. So how do other patients with other conditions like dystonia, MS, Parkinson's come through that service?
Yeah, so there's some big questions there, John. So I think the first thing is that it feels that you're talking about variation across Wales and the differences that we have, and that's something we are looking to address. So outside of this forum, there's another work stream that we've got which looks at neurorehabilitation offer in Wales, and what we're trying to do broadly is bring together key stakeholders in that forum to provide us a summary of the issues they face in Wales to provide good neuro rehab. So what that looks like at the moment is that we as a network would write down what the current neuro pathways look like in Wales compared to the optimal neuro pathways based in evidence. So we're going to write that bit up. We're then engaging with neuropsychology leads across Wales. We've got a meeting in the next week or so to discuss whether they could pull together a summary of what's good and what's not so good in Wales, and then their recommendations for things moving forward and how we can improve services. We're asking the exact same then of neuromuscular services. We're also asking the same of the WNA, so that we can ask them to contribute to that and let us know what is good and not so good in Wales and the recommendations. And also we're working with the UK ABIF, the Acquired Brain Injury Forum for the UK, their South Wales version, that sort of leg of it, to complete a service level questionnaire of community services to see what the offer is. Now their remit is largely ABI, acquired brain injury, but they've expanded those questions to help us capture what the variation is across Wales in the community services. And the aim on that big project is to identify the variation that you're talking about, so that we can then prioritize the recommendations and then set up the work groups that we need to start tackling those issues. it's a big piece of work. The timescales are slipping a little bit, because it's obviously hard to marry up all these different groups to contribute to one document, and then the prioritization of those recommendations, or the implementation or the work for those recommendations, is going to be on next year's work plan. So we're trying to get that wrapped up in time to produce that work plan. So I don't have any answers for you specifically today, but the variation you're describing might come down to some work that we need to look at in this group in terms of service specifications. How do we standardise or articulate what needs to happen in Wales? And that's open for discussion within this group. And then the national variation in terms of neurorehabilitation, where we're working to try and pull that together to describe that in some form, so that we can then start acting on it, and what is within our gift to act on, and what isn't, what needs additional funding, but is there different ways of working that we can make sort of significant changes towards, or start making tracks forward for. Does that sort of cover some of the things you mentioned there, John?
Yeah, thanks. I think what we're looking for going forward is we've got neural cafes mostly in each health board now, so someone come along and give us an update on what services they provide, and because most of the things we're hearing is that they didn't know they have this service in the health board. So if someone can come to each health board and give a short talk, and this is what's available, that'd be good.
That sounds like a good idea there, John. I'll take that as an action, and we'll try and work that up as a network and link with the right people. And if there's any volunteers within the group who'd be willing to go along to Neurocafe to help explain those the services available in those areas, then we can start marrying up those. And then just give me a thumbs up. I can't see the rest of the screen. I've got 3 faces on the side here. Sorry. So if anyone else is putting hands up, if the rest of the team could take note. But if not, we'll put that as an action. We'll go out to people.
Okay, thank you.
No, thank you, John. And then Reece, I think you were next with your hand there.
Yeah, thanks. Yeah, I just wanted to, from a patient perspective, just echo what John said. My care's bounced between 2 different health boards because of my obviously neurosurgery is based in Cardiff and Vale, and it's just a nightmare going between 2 health boards. And I can only echo what John's saying, that's a big factor, that certain services aren't available and the care varies depending on where you live. I think that's one of the biggest factors in Wales, particularly again in North Wales. I know the problems they have up there.
Yeah, I agree. I used to work in neurosurgery in Cardiff and Vale, Reece, so I understand the different services, and from a clinical perspective, trying to refer the people into the right service locally was really difficult.
That's been a big part of my care, because I've got a rare condition as well. It just going between having local care in Newport and Iron Bevan, and then having certain services based at Cardiff and Vale, and it's not convenient for the patient. I don't think the way it's currently set out and working.
Yeah. Reece, I wonder if I could come back to you and have a conversation with you about the experiences you've had, because that might play into some of the work that we might need to do later on around, as John said, what services are available, but also supporting clinicians in centrally funded services to know what services to refer to. And this has been a bugbear of mine for many years, and I've done some work on it, but it hasn't stuck. But we might have an opportunity to do something around that, with standardizing what the office should be, whether there should be, for example, a single point of access or referral point for every health board, for us to as clinicians to make that seamless. And that's part of the new standards that are being developed for the NICE guidance, that are due to be published in September, which we'll talk about in this forum. But I wonder, Reece, if you and I could meet and we could talk, if that's okay.
I'd be absolutely, because I'm one of the people I can speak out and fend for myself, and I feel for those people who aren't able to do that and put their point across. So I'm more than happy to meet with you, actually. Yeah,
thank you. And I suppose that offer can be open to anyone else with lived experience who's on the call, who would like to maybe come along to have a conversation around what they feel the issues are. And this is ultimately what I'm hoping the WNA will support us in feeding into this overall rehab review that we're pulling together. This type of conversation is what we're hoping to pull into it. Linda.
Just a thought. I think what you were asking is how can we, so at the end of sort of each of these workshops, that we would hope, I guess, that there would be some actions that each sort of health board might want to go away and work on. And if you're looking for suggestions, and I know that you know obviously the co-production team that talked last time from Cardiff, they use their Padlet quite a lot as like almost an interactive online whiteboard. That I guess could be, just thinking it's going to be quite difficult, I think, if we're all doing slightly different things, to gather what people are working on and seeing if there is making change. I don't know if it's something like that we could have like separate tiles for what Anira and Bevan are doing, what Cumtaf are doing, and we can look at what each other are doing then as well. I don't know, just a suggestion.
Yeah, that's a great suggestion. I'm not familiar with Padlet, so I'd need to be educated on that. This is a thumbs up from someone. I don't know who that's from, but someone who obviously uses Padlet, I'm assuming. But yeah, that might be something for us to follow up on. Thank you. And Stuart. So you're on mute there, Stuart.
My comment really goes down that John was talking about, and my experience has shown that there's something really important about helping users, patients, to know what they don't know. Many of the people out there just don't have any information, aren't able to interact because of that. So there is something about developing an expert patient cohort, which can really then help inform you from a position of strength rather than a position of not understanding the processes and what's around. So my point is about developing an expert patient program. It's been used in lots of different areas, and I've certainly found it's worked extremely well. Thank you.
Thank you, Stuart. Do you think that is something that we need to bring through this group, or to have a sort of cohort of expert patients to feed into the work that we're doing, or what are your thoughts on that?
I certainly think that could enrich this debate. I'd be interested to see what others feel about that, because it's obviously something that needs to be something everybody feels comfortable about. My own experience and my own feeling is it's very difficult to argue against upskilling your patient group to better understand what the service options are, but others may have a different view, and I'd be just really interested to see if anybody wanted to push back against that.
I think you'd be hard pressed to find someone to push back against that, Stuart. I think that's a completely reasonable expectation for people with lived experience to be given the knowledge to be able to make informed decisions about their care. And that links back to, as you say, John's point around, is there a way of us providing some of that in the first instance via these neuro cafes and giving people an understanding? And you're right, the issue, because so a big thing in my mind is sort of neuro rehab pathways, or pathways for a patient to receive the right level of input. People don't actually know what they should be getting. What is the national optimal? What is best practice? And in Wales, I don't think we really know what we should be doing either sometimes. So we do have these pockets and gaps, and I suppose what we're looking to try and do in all of the network functions is to make sure that we have a really clearly articulated service specification and pathway for the condition groups that are within the networks, to try and ensure that people aren't having variation in care, and that people have the equitable access and opportunity for the same outcome. So I'm really pleased this is the conversation we're having, because we're talking about variation and reducing variation and trying to standardize what's being put out there, and educating patients and people with lived experience. And that might be something we need to consider as we go through this forum. How do we bring all these pieces together so that we can all say that we're all working towards the same thing? I know we've got these standards, but we're not held accountable to them. As in the same way you might be with, say, a service specification or something, and we could support the implementation and audit of that. So that might be something for us to come back to. Okay, so there's no more points there. I've written some of this down, and at the end we'll go through actions, and if I've missed any, please shout out. I want to make sure we capture them appropriately. So I've come back to the agenda just so we can keep on track, because I've done a lot of talking, so apologies for that. So we've gone through the welcome introductions, terms of reference, audit evaluation. Now I'll be handing over to Linda and Bronwyn from AB UHB. So I'm going to stop sharing my screen, and I'm going to invite you to take control and show us what you've been doing.
Thanks, Nick. I'll have a go at sharing it.
The main thing I got from this whole thing was that we don't really know what they...
Okay, can everyone see my slides?
Yeah.
Fab. Okay, thank you for having us to speak today. So for those of you that don't know me, my name's Linda Tremaine. I'm a physiotherapist by background, and I'm the development lead for the Neurostute Recovery College in the Naira and Bevan Health Board. And I'm presenting today with Bronwyn Dawson. I don't know if you want to introduce yourself, Bron.
Yeah, hi everyone. My name's Bronwyn. I'm a trainee clinical psychologist. Currently, I'm working in community neuro rehab service.
So we were having a little think about this biopsychosocial standard and what we might add to the discussion. And Bronwyn and I were on a training session about trauma-informed practice a couple of months ago, and they talked a bit about the history of BPS. So I've shamelessly stolen some of the stuff they talk about and bringing it here for you. So just for a bit of background, the biopsychosocial model was pioneered in 1977 by George Engel, who is a prominent psychiatrist and a medical researcher. And he recognised that the traditional biomedical model for disease left no room for talking about social issues, psychological, and the behavioural dimensions of illness. And he proposed this alternative model in a seminal article. And I'm conscious that we have a mixed audience, and there might be sort of psychologists. I don't want to teach people to suck eggs, but just to give a bit of an example of what a biomedical approach might look like, we could use the example of managing spasticity or high tone. So the biomedical management of this would include things like Botox, baclofen, pain relief, electrical stimulation, using medication, splinting to manage spasticity. However, most practitioners and people living with spasticity will know that this is only half the battle. And if we were to think about other issues, the psychosocial factors, we might talk about things like stress management, a person's ability to engage with services because of mood, motivation, memory, proximal support, or they have family and carers, impact of housing, transport to get to appointments. So I can think of many cases in the past where a person's spasticity managed might have been optimized from a medical point of view, but that doesn't mean that their spasticity has been managed well. So I flipped the biopsychosocial to socio-psycho-bio, and hopefully it'll become apparent why through the course of our talk today. So social factors, there's growing research into the social determinants of health. And a lot of this work has been led by Professor Michael Marmot and the Institute of Health Equity. And I've just popped on the slide there, the World Health Organization defines social determinants of health as the conditions in which people are born, grow, live, work, and age, and people's access to power, money, and resources. These factors have a powerful influence on health inequities, and they are the unfair and avoidable differences in health status seen between countries. So the public health team at Naira and Bevan Health Board commissioned the Institute of Health Equity to do a report on how we're faring in Gwent in 2022. And the link on the slide there will take you to the Gwent report, which I'm happy to share my slides if anyone wants that. It's an excellent report. It's really worth reading, and it gives a baseline of where we are in Gwent in relation to health equity. There's lots of data in the report, but just to give an example of the kind of information they've pulled together, this graph shows the average healthy life expectancy for the 5 local authorities within Gwent. Healthy life expectancy is the average number of years an individual is expected to live in a state of good or very good health on a self-reported measure. And this data was gathered 2018 to 2020. And you can see there that women living in Torfaen will live on average for 55 years in good health, whereas women living in Monmouthshire will live on average for 69 years in good health. And that's a massive disparity for a region of Wales that the health services, in theory, are all the same. So people will be accessing the same, trauma centre, they'll be having the same secondary care. They might not have the same primary care, but in theory, those primary care doctors and services are supposed to be as equal as possible. So that's a massive difference. Just a couple of weeks ago, the Welsh First Minister, Eluned Morgan, has set out a press release to pledge that she wants Wales to become the first marmot nation. And this could be a stepping stone to all the regions of Gwent being benchmarked, and then also giving us something to audit against, whether we're improving, whether the things we're doing is actually making a difference to people's healthy life expectancy. So there was a quote on following up from this press release from the Royal College of GPs that I thought was kind of summarised this. So this sort of pledge recognises that the most significant determinants of health lie beyond the walls of our clinics and hospitals. Action on education, housing, transport, employment and the environment is essential if we are to create the conditions in which people can live longer, healthier lives. I'm just handing over to Bron there. Oh, you're on mute.
Sorry, I started talking without realizing. Just to follow up from that then, we can consider important questions then, like what does health and recovery mean for individuals? When changes do come, how do individuals cope with significant life changes often brought about by changes in health? And how can we support people to cope with these changes? And I guess it's important to mention here that we don't have to necessarily be psychologists to ask these questions, but these questions do draw upon, psychologically informed practice. And I just want to point out that there's lots of resources and frameworks and courses available, specifically more aimed for practitioners here, but to think about psychological factors in their practice. So here are some resources on the slide there that we've particularly found helpful within our team. So care aims we will cover a bit later. Traumatic Stress Wales have tools and resources that can be accessed by practitioners to increase awareness and understanding of how to become a trauma-informed practitioner and what exactly that means. So it's based on principles of safety, trust, choice, collaboration, empowerment and cultural considerations, which are really important. There's also the Welsh Applied Risk Research Network. So it's the WARN, provides a really helpful assessment tool to understand risk and how to manage risk. There's also Bridges as well, which is a supported self-management training for health and care practitioners. So it can support practitioners with things like research design, quality improvement projects, implementation and sustainability, and it can really help to embed learning into practice as well. And there's also Mellow, which offers free self-help resources for mental health. So just wanted to point a few out there. And then going back to what Linda was saying earlier about the social elements, I guess this is a model on the slide of like how the biopsychosocial model has evolved, and it's taken from Haslam et al.'s paper in terms of understanding health through our social identities and really emphasizing the social elements. So social identity basically is how we understand ourselves and behave as members of groups. So it might be easier to think about how your thoughts, feelings, and behavior can be different or change depending on the context that we're in. So it could be different when you're at home or at work, school, sports club. It can also be a change in larger scale groups like gender, nationality, ethnicity, social class as well. So I want to give a real life example of how we take this into a real life practice. So in CNRS in Aneurin Bevan, we have something called the Neurological Recovery College, which offers groups on exercise, peer support, psychoeducation, and it's run by practitioners, psychologists, and also people with lived experience. And it's designed to kind of support the needs of the biopsychosocial aspects of rehabilitation and recovery. And from these groups, service users have reported lots of benefits and positive feedbacks from engaging in these groups on their mental and physical well-being. And most of the time, service users report a lot of benefits from building social connections. And sometimes, more so than the actual content of the group. We've certainly found this in the psychoeducation group. And this is unsurprising, though, since this has also been reflected in research as well. So I guess alternatively, we can also think about, what it would be like for, say, a brain injury survivor if groups like this didn't exist and we could only offer biomedical treatments, like Lyndon said earlier, what would their recovery look like? And I guess I just want to kind of summarize this point by sharing a wise quote from Daryl Harris, who was our former consultant clinical psychologist in our service, and which I think captures the social psychobio really wonderfully, is that we're working with people within the context of their life. Then I kind of want to share with you a model to maybe think further about the social elements. They can be really complex, but this model can help to break down and understand how different elements of the social can interact and to influence health. I mean, it can be also a really useful tool to generate a person-centered understanding of their needs. So if we take an example of a person with a stroke, we can think, what's the available support that they have from people in their immediate circle. So like partner, family, close friends, with things like day-to-day activities, social and emotional support, financial support. If we think a bit wider then, do they study or are they in work? If so, are they being accommodated to meet their needs, or have they, perhaps no longer work or study as a result of the injury? And in turn, how does this interact with, how does the work and family interact for this individual? So, is there changes in routines, changes in finances, changes in family structure and roles within the family? And we can also think about how the person's family and the healthcare system interact. Are they able to attend appointments? They have a positive history with the healthcare service as well. And then we can also think wider about things like how does changes in welfare programs, education policies, social services affect the individual's ability to access resources and opportunities. We can take that further, step further then to think, how does things like culture and societal norms, laws, economic systems, stigma shape how the person's able to cope with changes after a stroke? So it's really layers, really, we can think of through this model. And on talking about like person-centered care, I want to share with you the Care Aims framework, which is a really helpful tool to make person-centered decisions on care and risk that follow kind of legal and ethical principles. And it's something that also shares principles of trauma-informed practice, like promoting collaboration, empowerment, and sharing information. And it really emphasizes understanding what matters most to the person's well-being, like what does health mean and look like for people, and who's most bothered by this particular problem issue that's being presented. And again, it emphasizes the circle of support as being a key factor of managing risk and promoting well-being. So this is also suggested by research that people's well-being is generally safer when they're surrounded by a network of supportive people. So based on that, the framework encourages services to consider how they can meaningfully contribute to supporting the person and important people involved in the person's life to recognize and understand and mitigate risk and promote well-being, and that services should step back after they successfully support the person to self-manage risks and their impacts. So I guess we've given you lots of information, and I kind of want to just present with you like a case example of someone called Alice, which is a pseudonym, and some of these facts have been modified to protect anonymity. But Alice is someone who's 40 years old, had a traumatic experience with stroke, which also led to a brain injury. It happened when she was quite a young age, and it was unexpected. She was previously described as high functioning and quite independent. And she's had extensive support from the service and has a really positive and trusting relationship with staff. And Alice's main goals are to move home and to be able to go out on her own. And I think both goals are tied to being independent. So to map out understanding the presenting issue, I guess, related to Alice, I'll go through the circles on the right of the slide there. So the presenting concern was that staff supporting Alice noticed that she was appearing low in mood recently compared to her usual self, expressing thoughts and feelings, signaling distress. Staff were growing more concerned about her and feeling stuck on how to support her, given that she was doing quite well in meeting her rehabilitation goals. So staff were presenting questions like, what should we be doing in this scenario? So it's helpful to understand this from asking these questions in the circle then and considering the biopsycho and social aspects that could be involved. So first, what led to the concerns? So this bit about Alice's history, she experienced trauma in her past, which led to many difficulties, including relationships and family members. Friendships also broke down after the stroke due to communication difficulties. And what could have triggered the concerns of, low mood and distress is that Alice recently experienced a relationship breakdown with her ex-partner. This may have led to some aspects of the traumatic experience and distrust of others to kind of resurface. But also Alice's ex-partner was her main source of support for her daily care needs and emotional support as well. And this meant increased pressure on her to complete daily activities independently and without the appropriate support she needs now. So what could keep the concern going is the breakdown in the relationship, meaning there was unmet social care and emotional support needs, which could have been interfering with Alice's goal of independence and therefore negatively impacting her mood. But I guess it's also important to highlight, what's preventing the concerns from escalating. So, the trusting relationship Alice had developed with staff meant she was able to notify them to call out for support. Alice continues to make positive progress in her stroke recovery journey. And this, importantly, the staff team identified and recognized that Alice actually had lots of other sources of social support outside of the service, like her friends and support groups she engages with. And that with the appropriate risk management in place to ensure her safety, it meant that staff could encourage and support Alice to seek and widen her source of emotional support outside of CNRS as well. And by linking in together, the biopsychosocial needs, we get a better understanding then of Alice's context, meaning that Alice's mental health concerns at present were likely related to drastic changes in her social relationship that had an impact on her daily functioning. So this meant that the team could identify how they can communicate a shared understanding of Alice's concerns with other appropriate services to collaboratively support her to meet her needs as well. So that's an example from me on applying the biopsychosocial model to understanding a person's needs. And I'll hand over to Linda.
Thanks, Bronwyn. So I'm just going to do a similar thing about a real person I worked with, but again, I've just modified some of the details to protect her anonymity. So I'm going to call her Kay. Again, she was a lady in her 40s who had a brain injury in 2021, resulting in a fractured skull. She had a subdural hematoma and a subarachnoid hemorrhage, and she had to have craniotomy, and she was in hospital for a very long time. And her background was that she was a secondary school teacher. She was a mountain climber, a skier, a very active individual, and had a real sort of massive friendship group around these hobbies and interests and work. So I broke down sort of some of the factors that were challenging in her case. She'd had a significant brain injury. So sort of looking at the biomedical issues first, she'd had a brain injury, which meant that she had weakness and high tone through the left side of her body. She'd been in hospital for a very long time because she kept getting infections, which then meant that she was very unfit, very deconditioned. She put on a lot of weight, and she developed pressure areas as well from challenges with her splint management. From a social point of view, some factors were apparent quite early on, that there was real challenges between the dynamics between her father and her brother. She lived in England in the Midlands, but had been visiting her parents at the time of her incident in South Wales. And it became clear during her rehabilitation that she couldn't go home. So she had to be discharged to live with her parents. And she was very distressed about this. And then the psychological factors that were coming out were that she was very, very low throughout her care. She was in hospital for about 18 months in the end. She was angry and irritable, and practitioners found her quite difficult to work with. And she talked about suicide often. She really couldn't see that there was going to be a life worth living after this. We worked with her, so she completed a community kind of standard, we used to have these very time specific, you'd have your 6 to 12 weeks of community rehab. And we'd been developing the NeuroStute model, and we sat down with the team. We were aware that this person had lots of rehabilitation, so lots of interventions, but she was not living well, and she was not feeling like she could manage herself despite the level of intervention she had had. And we didn't use this exact framework, but Bronwyn again had found this. She'd been on part of a training session with Dr. Stephen Barton, and I thought it was actually, this is a really neat way of mapping. What we did was we sat down as a team, and led by the psychologist, we started mapping out where she had been prior to the brain injury, and then what factors might be interfering with her moving forward with her recovery. And we asked, there's kind of prompted to ask questions like, what is driving some of these behaviours? What are her beliefs and values, and what are the beliefs and values of the people around her? And how is that interfering with her rehabilitation? Are we being considerate of the power and the impact of these things within the context of her life and the effect that they were having on her recovery journey? So I'm sorry, there's a lot of information there, but as I said, you can have the slides to sort of have a little look in more detail. But I just wanted to draw attention really that there were things like she'd told me that she'd always felt like the black sheep of the family, and she was a perfectionist. There was definitely some history within her relationships of feeling not good enough, and we joked about using the phrase "not good enough is not good enough," and that so that she was previously very independent, and her tribe, her community, were very heavily linked to her role as an educator, as a Zumba instructor, as a fitness person, as a mountain climber, and as a skier. And when we actually started writing the impact that those sort of the context of what she looked like as a person, how might that interfere with something as practical as her physiotherapy needs, we realized that we were never going to achieve perfection for her unless we had addressed the fact that she felt her whole life that she needed to be perfect. And after a stroke, perfection is very difficult to achieve. So we flipped what we were doing after a couple of discussions with the psychology team and with my manager, away from doing very kind of exercise driven, goal orientated towards walking and quality of walking, towards how can we help her to find a new tribe that would perhaps still fit in with her physical function. And we actually started reaching out to charity sector. We spoke to Ski for All in Llanelli, and they agreed for us to bring her down there for a session. And we also did some work accessing swimming pools, so ways that she could be fit and active without driving such high tone. And we had kind of a couple light bulb moments where we definitely changed the course of her journey with those 2 sessions. So when I think back to sort of what mattered most to this person, if you asked her directly in those early stages, she just wanted to go home. She just wanted to walk. You might get very broad answers like that. We were listening to what she was saying, but I don't know if we were understanding the impact of it. I don't know if we were pulling it all together until right at the very end, where we actually sat down and mapped it all out. And we didn't truly understand why she was so angry at us. And it wasn't that she was angry at us. she was being triggered to some really quite negative adverse childhood experiences, and the trauma of the stroke was making her relive a lot of this, and it was impacting on the rehabilitation. So yeah, I think it just really highlighted to me that even before, I'd been working as a physio for 20 years, considered myself a very holistic practitioner. But until I actually started putting the pieces together with colleagues and mapping it out, I didn't realize that how I wasn't being as person-centered as I thought I was. And I think, yeah, the sort of those landmark moments of changing what we do to focus on social connections, building a community of support. She is actually now a peer volunteer for us. She volunteers in a couple of our gym groups. I think she's still not living her best life, but she is on the road to recovery, and it's not required. We're not sort of trying to funnel her into a traditional system that would perhaps do 12 sessions of physio and then say, well, okay, discharge now. So I think the key learning points for me was that I felt I'd been given permission to do things differently, and that felt very scary even as a mature practitioner, and I sort of wanted to share that really with sort of that yeah, we need to be brave and we need to reach out into people's lives to help them actually move on from rehabilitation. I'll just put a tongue-in-cheek thing there. We don't have to use all our sessions for input. We can sit back and use some of our sessions for reflection and disciplinary discussions and connections. So, pass back to Bronwyn. Oh, you're on mute again.
Thank you. Sorry, I did that again. So I guess I want to just conclude with some take-home messages, and I guess emphasize that across these case studies that we've presented, I hope that we demonstrated that how the ways in which we approached the person-centered approach, by understanding the person's context through the biopsychosocial unmet needs, and appreciating that these factors are intertwining and they influence each other rather than being isolated things. And that we've drawn upon trauma-informed principles like ensuring those service users' voices heard and really collaborating with service users and colleagues to plan interventions and the best ways that we can support individuals, and by asking questions like who's bothered, what matters most when we're making decisions about referrals and treatment approaches. And like Linda said, by considering the social circles and the tribes that are, can be a great source of strength and support for individuals. And I guess, the take-home messages are that the biopsychosocial model continues to evolve. Now it's looking like it's going in the direction of perhaps more emphasis on the social factors. And like I said earlier, we can really understand a person's context and complexity by mapping out the biopsychosocial factors. And this can help us to identify where the unmet needs could be. And that models and frameworks can be really useful tools to draw upon to devise a person-centered treatment approach. So then I guess we want to just acknowledge Dr. Stephen Barton and his colleagues for the biopsychosocial, the table and the map that Linda shared earlier. I don't know if I should hand over to you, Linda, for the last bit here.
Yeah, it's only if anyone's got any questions. I've put a QR code there for anyone who's interested in more information about the NeuroStute. And Bronwyn and I are both happy to be contacted by email. So yeah. Hiya, shall I go? Do you want to say anything, Nick, or shall I have a chat with Rhys?
Please bring Rhys straight in.
Yeah, go ahead, Rhys.
So I just wanted to say, yeah, that was fantastic. I had to sort of reinvent myself multiple times and having various. First of all, when I was a kid, I was a footballer. I played for Cardiff City. And then I had the brain tumor, and then I had the VP shunt put in, so I wasn't able to play anymore because I got knocked in the head. So I took up music, and that became my life. And then, obviously, going deaf, then I'm unable to perform and play now. So I can still play with my hands. I just can't hear it, so it's no fun anymore. So I've had to find myself again, and I feel very fortunate. I've managed to, through neurorehabilitation, I found recumbent trike cycling, which I joined the board now at Pedal Power in Cardiff as a patient advocate, to use my lived experience to encourage more people to get involved. And it's just about finding what you're able to do with the condition or whatever predicament you're in. And I feel, you know, what Linda's just gone through, I had none of that input on my personal case. I sort of found my own path. And so I feel fortunate I'm able to do that, but I think it's right in sort of, you have to tailor it to the individual person. Everyone's different, but they need to find something they can enjoy and, you know, to give them fulfillment in life, because that's the big thing I felt that I was lacking, particularly when I lost my hearing. So I felt that's really good talk, both. Thank you very much.
Oh, you're welcome. No, that's great. And that's been weirdly my journey as a practitioner as well. Sort of reinventing myself and sort of watching, sort of thinking that, oh, I know what I'm doing, you know, I just got to do this. And then you sort of hear this other perspective and you realize, oh, actually. So I think we're all growing and changing and learning. But I think we do get a bit, especially in big services like NHS, it's almost like, no, that's not my bit to do. I do this bit and then I leave it for someone else to do that bit. But what we found in our team is that actually, especially in my lady's care, I think physio had the best relationship with her. But if I'd have worked with her in kind of a traditional way, I know that we would have come to a point where I would have had to have said to her, I'm sorry, we can't do any more with you. And she would have been left, which is possibly what your experience was. And that I guess it's that I use that word permission. It was sort of reasoning with my manager. It did take a bit of time, but I think we would have saved that time in the long term of her trying to kind of bounce back through, or potentially even worse. You know, she talked about suicide risk a lot, and she does when she tells her story herself, she does say that, you know, she might not be here today if we hadn't have really kind of helped her steer through that. So when we're talking about kind of life or death, it is worth the time to try to, it's worth our resources, and it is in our gift, like Nick said. But we need this community of practice, because I'm aware that there are regions of Wales that might not have brain injury services, they might not have psychologists that they can easily call on, but I think we are definitely getting better at networking and sharing learning. And I think certainly from our point of view, we're happy to talk to anyone from any health board. If you're ever feeling isolated and not sure, please reach out, especially within the Recovery College. We view the Recovery College as something that can help broader than just an Iron Bevan.
No, that's brilliant. Thank you. I actually bumped into one, Eleanor Cap. I don't know if anyone knows Eleanor. I bumped into her. She's a psychiatrist, and she was an Iron Bevan for years. She just written a book, and she overheard me talking about my story and gave me a copy about her book. So it's interesting, because I find just being in that environment as well, you meet people as well, which I think is one of the biggest things, because, you know, I lost so many friends just because they can't do the things I used to do. They don't want to know anymore. So it's just a case of finding that motivation to try and move forward with people that you can associate with as well. And I think that's one of the biggest factors for me.
Yeah, it's a good use of NHS resources to help people do that bit.
Yeah.
John, do you want to come in?
Yeah. Very good presentation, thank you. Our neuro cafes would fit really well with this.
Yes, I have made a little note to find out where my Iron Bevan neuro cafe is.
The big, I think when we started off neuro cafes, Michelle Price was setting one up first in Powys. Powys was a big, massive area, and we thought it would work better in the South Wales valleys, because we were all like talking. So social phobias is probably the biggest problem we have. Loneliness is a big problem. I first met a gentleman who'd lost his wife, and the other person had a brain hemorrhage, and he wanted to talk to people as well. So I sat and talked to him, and he said, and I could see the confidence building up. You know, the talking, the confidence and all that. And 4 years later, they still meet in a coffee shop and have chats over rugby, over, you know, everything. So we set the neuro cafe up because my involvement in neuro cafe with social phobias, and we've got 6 neurological conditions supporting our neuro cafes, and then, you know, other charities now are doing a lot with social with the new cafes around Wales.
Yeah,
So just like to say, yes, it fits with what we do in, and like to have like
absolutely.
a conversation with you at some point.
Of course, yeah, definitely, John. I'm happy to connect. Yeah, I'll send you an email after the session today.
Okay, thank you.
Well, just to help support that then for others on the call, and John, if we could work with you to identify where you have neurocafes currently, and we can try and link you in with the right people in the services, so you can have the conversation relating back to that action point earlier around trying to understand what services are provided in those local areas. Ellie, do you want to come in?
Yeah, I just want to highlight there's a question in the chat as well from Larry Heath asking to say thank you first off for the presentation. And did you have any OT input with identifying new roles and meaningful occupation?
Yes, yeah, this lady had a lot of intervention through the stroke discharge service, and it was multidisciplinary, and she was having one-to-one psychology, she was having input with OT and input with physio, but she really wasn't able to engage well. And I think and the practitioners, there was a lot of tears. She would be really quite, and she doesn't mind me saying this, it was a very dark time for her, and she would be quite aggressive, and people found it very difficult to work with her. So there's a few OTs who couldn't work with her afterwards, and I think that the thing is that her anger was interfering with her ability. We knew that her goals were around skiing, but we weren't empathizing and understanding where her anger was coming from. We couldn't get past that in traditional rehabilitation. And what I wonder is, we only addressed all of this right at the end of her care, whether these sort of conversations could have gently been held earlier on, maybe it would have been a different pathway for her. And I'd like to think that moving forward, there is a goal. Traumatic Stress Wales want to kind of have trauma-informed practitioners across the board. Yeah, I don't know, does that answer your question?
Yeah, that's great. Thanks very much. Just because as an occupational therapist myself, obviously I really resonated with a lot of the information that you gave in your presentation, and it's a core part of our role as OTs to look at loss of role and meaningful occupations, and obviously we all know the important impact that has for patients living with longer term conditions in the community. So yeah, that's great, but obviously it sounds like it was quite complex in terms of managing, finding the appropriate clinicians that were able to work with her and finding a way in. So yeah, that's great. Thank you.
I'll let Stuart come in. I've just got a few comments really. So I'll step back, and then Stuart, if you want to come in.
Oh, you're on mute.
Thanks very much for that. I think my comment is really just reflecting on the real positivity that's coming out, which is actually all around two areas, I think. One is putting the individual at the centre and using the model that's been propounded, which I think is really important. And also, it's about avoiding what I term silo working, where as professionals we can very often get into situations where we look at our issues and the issues that are specific to us. So as a physiotherapist, it's about movement. As an occupational therapist, it's about your issue. And what we need to do is recognise and realise that, of course, the patient doesn't look at professions. The patient looks right across all those issues, and that's where the actual goal is as a professional, is being able to recognise and maintain that it's the patient's view across the professions which is the real goal. And if we can do that that's I think the way we go forward. So just getting away from the danger of silo working.
Yeah, I totally agree. I totally agree. It is difficult in certain areas of practice. And I think, again, just the way the NHS system is set up, it doesn't lend itself easily to it. And also, we know that we haven't had the full MDT present, certainly in neuro, in mental health, they sort of there's been this divide that there's mental health over there and physical health over here. And
completely get that.
Yeah, neuro conditions are perhaps, I think, going to lead the way of really showing what integrated care can look like, because now we actually have got skilled psychologists, OTs with that bring much more creative, psychologically aware practices, and then a kind of broadening skills for myself just as a physio. Sorry, I shouldn't say just a physio, but to actually, because it's not a switch, it's something that you have to learn and you have to have time to reflect on, and you won't always say the right thing, and then you have to kind of look. So it's a process that has to be scaffolded by the wider network.
You're so right, Linda. I think I've been a professional for, well, I'm recently retired. I was a professional nurse for 40 years, and I've been through and had all of these conversations actually over 40 years, and I don't want this to be desperately negative, but we've been discussing this for at least 30 years that I know of.
Yeah.
And it's, unfortunately, we can get into a situation where this becomes cyclic.
Yeah.
So we just keep going round and round in a circle. And the trick is, through this sort of a group, to break out of that circle and allow ourselves to look in a far more beyond the horizon way.
Yeah, I totally agree.
I agree with this. This is such a good conversation. I'm so pleased these conversations are happening here. I just want to touch on a few points. Stuart, you mentioned about sort of professions working on certain aspects of a person's in certain domains, and that's exactly how we're taught. We're taught to classify impairments via the International Classification of Function and Disability, and there's often impairments which are physical problems, and there's sort of environmental, contextual issues, and sort of functional issues. And our interventions are typically designed to target aspects of those, so the impairments of the body and the structure and the function. And what I've found in my career is the more experienced I became as a person, the more I was able to take in the personal issues of someone living with a condition and support that aspect. So I think there's something within our training of clinicians and how we can maybe, there's something for us to consider when we're training clinicians in across the disciplines, which I know there's more of a collaborative approach at university level. But it also makes you think a lot about the services that we work in, and we're governed by certain things. So Linda, you mentioned sort of 6 to 12 weeks rehab, and then having to have conversations around, well, can we change that? Can we work more flexibly, bringing in third sort of partnerships and third sector? And I just wonder what your take on that, the difficulties you had around trying to get the agreement to do things differently from perhaps a professional point of view, because people sometimes feel like, because I know if that scenario came to me when I was a younger clinician, I probably don't feel like I would have the personal capacity to deal with the complexity, not necessarily the professional, well, maybe the professional as well, actually, in terms of my clinical skills, but certainly the personal. But then also from a service point of view, the difficulties you had in presenting that as a need for the person rather than the service provides X, but they need Y. If you're able to talk about that a little bit.
Again, I know it's not the same everywhere, so I really feel for people. We were lucky because the brain injury service was set up in 2017, and our manager was very kind of a compassionate leader and really open to new ways of working. And rest his soul, Dr. Daryl Harris, who I will talk about until I have no breath left in my lungs. He having these kind of inspirational leaders that are willing to kind of take small risks. We sat down and we thought, okay, well, what are the risks? Why is it such a risk for me to take 3 hours of my time to go and show this woman that skiing is possible. And it felt, oh, is this a good use of NHS resources? And is this my job? Is this, and I have had not criticism, but, I have been challenged about whether that's our place. So that's what social services are there for. But when you look at the funding model of what NHS get compared to social services and where we are funneling that money, I just think if we keep siloing and saying, nope, that's social services job, then we're going to end up with a really unhealthy population. We actually are in a really beautiful position where we've got a chance to gain trust with people at the worst time in their lives. If we can work with them kind of in a way that gets to know them, that then they trust us to kind of get them on their recovery journey. And if we can broaden the way, Daryl's view of a recovery college model instead of a rehab model, it really does kind of flip the narrative away from us delivering treatment to people, more to how do we learn to live with. And that might still include rehabilitation, but it's not the primary focus of why we're involved. We are here to support people to live the best life they can with what they've got.
Yeah. And the process of going through that journey with an individual can be therapeutic in itself, can't it?
Daryl always said that. Yeah,
He's
Daryl always said that.
Rubbed off on me as well.
He did, yeah. I think we just need a few more psychology voices. and just, but I laugh at that, but I actually think that's the thing that's changed my practice most, is actually being able to have that different lens on how I deliver my care. And sometimes I will do a whole physio session and I won't touch someone, which, like you said, 5-10 years ago, that wouldn't have crossed my mind,
Yeah. If it's okay with the group, Rhys, if you're right to have the last question here, I'm conscious of time. I really want to get into this interactive session with all these good conversations we're having here, because we can try and formulate what we feel a service needs to be able to provide this level of care, to really deliver on this standard, and to try and discuss the current barriers and the levers, so we can try and articulate that. And myself and the rest of the team will be in those breakout rooms and we'll try and capture that, so we can try and formulate that and play that back to the group. So if that's okay with the group, I just want to make sure we can capture and harness this. So Rhys, are you okay to have the last question on point there, please?
Yeah, I just wanted to add, from my personal experience, the thing I think that made it more bearable for me is that we had this whole process years ago where it was doctor and patient separate, and now it's more of a case of my doctor, Tom Hughes. I found him very personable. We could interact as people as well as doctor and patient. And Tom, I recently went to Boston, Massachusetts to share my story last week, and a week before last, and Tom was supposed to do a presentation, but he couldn't log in, unfortunately. But it was about his presentation was about us working together. Me as a patient, learning from my lived experience, and he wanted to put that across. I was very gutted he couldn't get to log in, but it was about working together as patient and doctor, not them and us sort of environment. And I think that meant a lot to me. The same with my neurosurgeon, George Errolil. You've probably seen him on the telly recently, but what a guy he is. He's such a nice person, and you can relate to him as people, not just as, in the environment you're in. And I think that's the most important thing for me, is being able to have that bond with your physician to work together.
Yeah,
absolutely. Yeah, completely agree. Okay, so if people are happy to now, I'm going to ask Emma and the rest of the team to try and organise this into some breakout rooms. They've got the questions in the room, but what I'll do is I'll just if I quickly share what we're going to talk about in this room now, so we can just focus our minds. So if you can see a slide there, essentially I've called it a blank page exercise because I really wasn't sure what to talk. I just want to see what comes out of it. But I want people to consider these 3 things, and you'll be supported through the session as well. So if you're designing a community service for people with neurological conditions, what key aspects would need to be in place to provide good biopsychosocial care? So what things need to be in place? Immediately in my head, from the conversations we've been having, the things like staff and the skill of staff, the support that the staff have to make changes, the type of service that we're in, what does the service offer, how can we, what needs to be in place within the service, the flexibility within the service, other things might come up as well. So I won't lead too much, but they're types of things we've been talking about. So I'll stop sharing, and then hopefully we can sort the breakout rooms. Is Emma, you going to do that for us?
Hopefully. Give me a second.
Okay, and then
I'm going to stop the recording, so I might have to pop out and then join in on the Neuro email address. So please bear with me 5 minutes, people, while I try and get you sorted. So just bear with me for 5 minutes. Thanks, you. Emma.
And then just to let people know that myself and the rest of the guys with similar backgrounds, or it's from the Now Performance Improvement, will be taking notes along the session and trying to facilitate where we can. So if we're just slightly distracted, it's because we're trying to capture all the good conversation that's happening. And so we are going to record as well, but we'll do what we can. The anticipation.
Nick, have you got the breakout room option on yours?
I think it's through the organizer, which was the
it's only the organizer. Yeah, that's as I wasn't sure who the lead person was.
The Neuro inbox.
There we go.
And thank you for all the links there, Michelle.
Welcome.
Yeah, I was just going back through the chat, and I just I apologize for any acronyms that I was using. I didn't realize we'd have people with lived experience here today, so but I love it. I'm really glad you guys are in the room. But I think I might have made it. If there was anything that you didn't understand, please, obviously, you could have interrupted me.
Yeah.
Right, this isn't going how I want it to go.
Is there anything I need to do, Emma?
I don't know if you can take control, because it hasn't given me the option to take control and do the breakout rooms.
If I share my screen, I might be able to. I can give control. Layout optimize. No, I can't.
Oh, it should have let me do it. Don't know what's going on here.
I can see now. Oh, so when you were sharing then, Nick, the take control option came up.
Okay. So I've got give control. Do we need to stop the recording, did we say?
Yeah, let's stop the recording while we try and figure this out.